Okay, once again, welcome everyone to the CIRA Talk series. CIRA is a Center for Interdisciplinary Research on AIDS, and we are an HIV/AIDS research center at Yale University funded by the US National Institute of Mental Health. Today's event is organized by CIRA and co-sponsored by the Center for Methods in Implementation and Prevention Center, CMIPS. And my name is Dini Arsono. I'm the coordinator of CIRA's HIV/AIDS International Research Programs and one of the co-hosts of today's event. On your screen is a screenshot of CIRA website, cira.yale.edu, where you can find information related to affiliated individuals' research projects, presentations from past events, and other resources. If you are new to CIRA, I would invite you to visit the website and browse, and also sign up for the monthly CIRA e-bulletin or newsletter that is available to the public. So we have a couple of several upcoming events in April. The first two events are convened by the Yale School of Public Health Department of Social and Behavioral Sciences, SBS, and co-sponsored by the center by CIRA. And then the next CIRA talk will be held on April 19th at 1 p.m. Eastern. And it will be on SANCOVA 1 and 2, implementation research to optimize disclosure of HIV status to children in Ghana. And information of these events we will be sharing with everyone after this talk. So feel free to attend if you are available and interested in the topics. So the presentation today will be followed by a discussion and Q&A session. To avoid audio interference, please keep your mic off unless otherwise directed. And feel free to use the chat function to submit questions and comments. At the end of today's event, I would like to invite you to share your feedback in a very brief survey to inform our future events and activities. So today's CIRA talk, Integrating Hypertension Screening and Treatment into HIV Care in Uganda, will be moderated by Dr. Luke Davis. Dr. Davis is an epidemiologist and pulmonary critical care physician whose research employs implementation science to improve the diagnosis, treatment, and prevention of tuberculosis, the leading cause of infectious disease death in low and middle income countries. Dr. Davis serves as a scientific advisor for CIRA's international research activities and a co-chair of the Yale Global HIV/AIDS Research Network, or GARNER. Dr. Davis is also associate faculty member of the Center for Implementation and Prevention Science at the Yale School of Public Health. And with that, I'd like to turn it over to Dr. Davis. Thank you.
Thank you so much, Dini, and welcome to all the attendees. I also want to welcome today's discussant, who I'll introduce, Dr. CIRA Hassan, who is a physician trained in medicine and pediatrics and also a scientist. She's based at the Emory University School of Medicine, where she's an assistant professor, and her clinical home is at Emory Midtown, where she participates in resident education. Dr. Hassan is an implementation scientist with a research interest in addressing the needs of people living with non-communicable diseases, especially in the setting of climate-induced disasters. And she has research projects currently in the Caribbean, Sub-Saharan Africa, and mainland US. She's a member of the Emory Global Diabetes Research Center and affiliate faculty at the Center for Humanitarian Emergencies. So welcome, CIRA. I really appreciate your joining us today. I also want to now introduce our current presenter, Dr. Martin Mudu, who is a physician and PhD candidate at Makerere University in the Infectious Diseases Research Collaboration in Kampala, Uganda. In addition to his internal medicine training, Dr. Mudu has additional training in implementation science. And Martin is a research scientist at the IDRC in Uganda and also a PhD candidate at Makerere University. And this semester, he's a research scholar at Yale, courtesy of the National Institute, the Fogarty International Center, where he has a K43 award as an emerging global health leader. His mentors here at Yale include myself and also Dr. Moses Kamya, who's a professor at Makerere University in Uganda. His research focuses on the use of implementation science methods to integrate the management of chronic non-communicable diseases, especially hypertension, into HIV care and resource-constrained settings. So with that, I'll turn the mic over to Dr. Mudu. Thank you for joining us today, Martin. Looking forward to hearing your talk entitled Integrating Hypertension Screening and Treatment into HIV Care in Uganda.
Yeah, thank you, Dr. Luke Davis, for that kind introduction. And thank you, the CIRA team and CMIPS for inviting me to share our experience. Let me just share my screen. Okay, good morning, ladies and gentlemen. Good evening and good afternoon. Thank you for coming to attend this talk. I'm delighted to share some of our experience regarding integrating the screening and treatment of hypertension within HIV care in Uganda. And thank you, Luke, for that introduction. In today's talk, we are going to focus on three main areas. One of them, we are going to look at the epidemiology of high blood pressure among people living with HIV. And we'll also look at our approach to designing and evaluating an implementation strategy, which we used in Uganda to help us to integrate the management of hypertension into HIV care. And lastly, we'll look at our next steps, which are going to focus on integrating the management of hypertension into community-based models of HIV care in Uganda. Many of you may be asking yourselves, what is the burden of high blood pressure among people living with HIV? And to answer this, I've shared a snapshot of what is happening regarding the HIV care, but also what is happening regarding hypertension care within the same HIV care program. So for Uganda, we have a population of about 45 million people, and we have a relatively high prevalence of HIV. Uganda is one of the endemic countries for HIV with a prevalence of 5.3. And there has been significant progress regarding HIV care. Over 80% of people living with HIV have been tested and they have been identified. They know their HIV status. And of those who have been tested, 96% are actually receiving antiretroviral treatment. The UNAIDS requires 95% of these indicators. And of those who are actually on treatment, we see 92% have been able to achieve HIV viral load suppression. So this is really good progress towards HIV epidemic control in Uganda, and the picture is similar across many other sub-Saharan African settings. On the other hand, when we look at hypertension among people living with HIV, we have a very high prevalence of hypertension, much higher than that of HIV. About a quarter of adults living with HIV have high blood pressure. And very few of these are actually aware that they have a high blood pressure, meaning that many of them have never had a blood pressure measured for them to understand they have hypertension. Less than 10% are aware, and less than a fifth are actually receiving treatment for high blood pressure. So when you look at hypertension control, for those who get treatment for high blood pressure, it's only about only 5% are actually achieving high blood pressure control. So you can see that within a successful HIV program, among people living with HIV, we have suboptimal care for hypertension. So what about in the general population? Still, we are seeing a very high prevalence of hypertension in the general population, ranging between 20 to 30%. And still, awareness and control of hypertension in the general population is still suboptimal. So the picture among the HIV positive clients and the HIV negative clients is similar suboptimal care for hypertension. So this picture really calls for a lot of effort, but we thought that to turn around this picture, we needed to integrate the management of hypertension into HIV care, because already the HIV program is well established. But how do we utilize that opportunity to be able to offer additional services for hypertension? And the rationale is quite strong because we know HIV is a risk factor for hypertension through a number of mechanisms. And one of them is the chronic inflammation, which occurs as a result of the HIV infection itself. And chronic inflammation in the blood vessels really increases the risk for high blood pressure. We also know that some of the antiretroviral treatments may increase the risk for high blood pressure, but also the HIV population is aging. Over 20% of the people living with HIV, their age is 50 years and above. So all those are risk factors that increase the burden of high blood pressure among people living with HIV. And still, if hypertension is not treated and if it's not controlled, itself, it's a risk factor for heart attacks, strokes, and other cardiovascular diseases. And because of this, the World Health Organization since 2016 has been recommending integration of non-communicable disease care, hypertension, and other diseases into HIV care. And the Ministry of Health in Uganda and other ministries have adopted these guidelines. So in addition, the World Health Organization came up with the WHO HEARTS guideline, which really brings out very clear guidelines that can help low and middle income countries to manage hypertension better. And these can be applied both in the general population, but also in the HIV program. But prior to our studies, we did not know the feasibility of these guidelines within the HIV setting. So as we proceed, you will see that the WHO HEARTS guideline was a key pillar for us to try to work out integration of hypertension into the HIV program. So you may want to understand what the WHO HEARTS really means. So the the World Health Organization came up with this guideline, and the way you see the HEARTS itself, it stands for a number of elements. So the H standing for health lifestyle. We know that for hypertension management, there are a number of lifestyle measures that can help in the management of hypertension, including physical exercise, smoking cessation, eating a healthy diet, cutting down on alcohol. So that component really is focusing on healthy lifestyle. The other component is evidence-based treatment protocols, because if providers do not have simplified treatment protocols, then they cannot provide good treatment for hypertension. And we've seen that protocols are very helpful in the HIV program. And that is one of the reasons why the HIV program has succeeded. So WHO is recommending protocols. Access to essential medicines for high blood pressure is the other element. The other is risk-based cardiovascular management, which focuses on profiling all patients who have hypertension to understand their cardiovascular disease risk and provide care to them based on their cardiovascular disease risk. The T standing for team-based care, and the S for systems for monitoring. So that is the WHO HEARTS guideline, and you will see how we adopted this guideline to help us to integrate the management of hypertension into HIV care in Uganda. So what was our approach to designing the implementation strategies that we used to integrate the management of hypertension into HIV care? So for us to come up with a strategy, we designed a study which had three parts. One of them was to map the care cascades for hypertension and HIV within the HIV programs. So we wanted to understand the performance of the cascade for hypertension and HIV in order to identify the implementation gaps and be able to target our strategies and interventions effectively. In addition to that, we wanted to understand the barriers and facilitators, the reasons why implementation gaps existed along the HIV and hypertension cascade, but with more emphasis on the hypertension cascade. And lastly, we used implementation science methods to adopt the WHO HARTS guideline to help us to integrate hypertension care within the HIV setting. So to start with, I'll show you, we conducted a number of studies to understand the cascade of care, both in the rural setting, in the rural clinics of Uganda, and in the urban setting. And these cascades, as you will see, we conducted them through a retrospective data review. We abstracted data from patients' records and the electronic medical records within the HIV clinics. In the rural areas, we had a number of clinics and one large HIV clinic in the urban setting. But for this, I'll focus on the large urban HIV clinic setting. And we looked at data for HIV care cascades, right from screening, making a diagnosis for hypertension, looking at treatment initiation for those who are diagnosed with treatment, and then control. We also determined a similar cascade for HIV within this HIV program and looked at those outcomes for a period of 12 months. And the main outcomes that we looked at, as you can see from the cascade, screening, diagnosis, treatment, monitoring, and control. So this was at baseline before we intervened. But you can see that on the y-axis, these are the people living with HIV who also had hypertension, getting these services along the care cascade. Orange standing for HIV and blue standing for hypertension. You can quickly see that the HIV care cascade was functioning quite well, almost achieving 100% along all the service indicators, right from screening, diagnosis, treatment, and control. On the other hand, the hypertension cascade was performing suboptimally, especially initiating treatment for those who are diagnosed, retaining them on treatment, monitoring them, and getting them to control. Almost less than 10% of the patients who were diagnosed with hypertension, it's only about 10% who received treatment, and subsequent cascade steps were also dismal, like you can see. The good thing with the hypertension cascade at that time is that the clinic was actually screening everyone for hypertension every time they showed up at the clinic. But screening and after diagnosis, treatment was not happening. So those are the key gaps that we saw. And from this, we wanted to understand the reasons why these gaps actually existed and how we could design strategies to close these gaps. So to understand these gaps and the reasons why these gaps existed, we conducted a qualitative study to understand the barriers and facilitators for integrated care for hypertension within this successful HIV program. And this was qualitative. We interviewed patients and their care providers, as well as leaders in the healthcare system, including participants from the Ministry of Health, to get a health system's perspective of why these gaps exist and how we can work around to close these gaps. And we used thematic analysis and we used the consolidated framework for implementation research to map these findings onto that framework, because that framework helped us to visualize the health system through a number of domains, looking at the intervention that we're talking about, integrated management of hypertension in the HIV care, the patients, the providers, the policies, the external participants, and the processes of implementation. So the CIRA helped us to analyze these barriers and facilitators in a healthcare system perspective. And what we found is that the key barriers for this integration, the key barriers for management of hypertension in the HIV setting were mainly four. One of them, poor access to medicines for hypertension. As many of you may be aware, we have a lot of support from the PEPFAR program, and all these HIV clinics have adequate antiretroviral treatment. But when it comes to medicines for hypertension and other non-communicable diseases, the medicines are usually not readily available. And then these clinics do not have treatment protocols and guidelines to help them manage hypertension. Although they had guidelines for HIV and other opportunistic infections, for NCDs, these guidelines were not in place. And the monitoring system for hypertension and other non-communicable diseases was not there. Yet we have a very strong monitoring system for HIV, including an electronic medical record system. But there were no elements to capture data for hypertension. So those were key barriers. And lastly, the healthcare providers lacked the essential knowledge and skills to manage hypertension. Because when patients were diagnosed with hypertension in these clinics, they would be referred to tertiary hospitals or to other places where they could get treatment. So those were the key barriers. And just to point out an example of some of the experiences that healthcare providers shared when we asked them about their experience regarding treating hypertension in the HIV clinic. So one of them said that the topmost of things is medicine. So drugs, drugs, drugs. So we are doing well regarding antiretroviral treatment. Even our HIV viral suppression is 97%. But for hypertension, we have done nothing. It is beyond our control. We can't buy hypertension medicines. We just prescribe and encourage our patients to go and buy. So that was one of the healthcare providers really expressing their frustration with the status at that point, because they were able to manage HIV quite well, but they were not able to manage hypertension well for the same patients. But the opportunities that existed at that time, or the facilitators that could help us to integrate hypertension management, is that some clinics already are performing the blood pressure measurements. Like you can see this nurse here at one of the large clinics in Uganda measuring the blood pressure. But after measuring the blood pressure, if this client turned out to be hypertensive, they may not have the medicines to give her. Then we also have an electronic medical records for HIV, which we thought could be leveraged to improve the monitoring for hypertension. And these existing HIV clinics, which are really in almost every part of the country, is a good opportunity to really integrate the management of hypertension. And there was a lot of enthusiasm from both the providers and the patients for integrated care. So having looked at the patients and the providers' perspectives and their experiences and preferences, then we wanted to design a strategy to help us turn around the picture that you saw, to bring the indicators for hypertension, to bring the services for hypertension closer to the HIV quality of care. And we constituted a multidisciplinary team, including HIV healthcare providers, some experts from the Uganda Heart Institute who have experience with managing hypertension, participants from the Ministry of Health, and some participants from the PEPFAR implementing partners. And we looked at the key barriers and the facilitators that we had seen and came up with some strategies to help us integrate the management of hypertension into HIV care. But in this design, we adapted the WHO HEARTS guideline that you saw. So we did not take up the HEARTS guideline in whole, but we took up parts of it and came up with a strategy based on the barriers and the facilitators through engagement with these stakeholders. So these are the components of the WHO HEARTS strategy, which we adopted through that engagement with the stakeholders. The key thing here, we developed an evidence-based treatment protocol, because this is very important to help healthcare providers, including doctors and the non-physician healthcare providers. Even a nurse can use a protocol and prescribe medicines for hypertension after making a diagnosis. We also provided free hypertension medicines to this clinic, and patients were able to get this medicine free of charge. We also provided some aspects of task shifting. because we know in these clinics, doctors are not many. So we shifted some of the tasks for prescribing from the doctors to the nurses. So a doctor would prescribe. If the doctor is not available, a nurse could actually prescribe these medicines to the patient using the protocol. And also we trained the lay care providers. These are called expert clients of people living with HIV peers to be able to measure blood pressures using automated BP machines. And this could take away some of the burden from the nurses and other healthcare providers. And lastly, we put in place a register for hypertension management. Initially paper-based register, but we made it electronic. So those were the 5 components of our strategy, which we developed through engagement of stakeholders, but adapting it from the WHO HATs. And the letters you see on top here really point you to where this was adapted from the traditional HATs, E referring to the evidence-based protocol, A referring to access to medicine, team-based care, and S for systems for monitoring. So this is the strategy that we implemented. And many of you will want to understand how did we implement this and what happened when we implemented this. But before we talk about the outcomes of our implementation, we want to show you how we selected the medicines that we included on the protocol that we are going to look at. And the decision to select our medicines for the protocol was based on this landmark trial, which was conducted across sub-Saharan Africa and in many countries, including Uganda. And in this trial, 3 groups of patients who had hypertension were randomized to receive different combinations of medicines for hypertension. And the main outcome of interest was blood pressure at 6 months. So we looked at this trial and looked at the most optimal treatment that was showed by this trial, and we tried to adopt those combinations to our implementation strategy and put that medicine into a protocol. So from this trial, the different groups of patients who had hypertension were randomized. One group received amlodipine and perindopril. For those who are not clinical, you will excuse me, but just to simplify for you a little bit, these are different classes of medicines for high blood pressure. So calcium channel blockers, an example is amlodipine. Perindopril is in the angiotensin converting enzyme inhibitors. So we had amlodipine, perindopril, amlodipine with a thiazide, and then perindopril with another thiazide. So those were the different combinations for these hypertension medicines. And what this trial found is that a combination of amlodipine and perindopril had similar outcomes in terms of blood pressure control compared to amlodipine and a thiazide. And this is what I am showing here. So group 1 and group 2 outcomes were similar, but blood pressure control in group 1 and group 2 were superior to those in group 3, meaning that a combination of amlodipine and perindopril performed as well as a combination of amlodipine and thiazide. But either of group 1 and group 2 performed better compared to group 3 combinations. So from this, anyone who is designing a regimen for blood pressure management would agree that you would at least pick amlodipine and include it in your regimen, because where you have amlodipine, you have better treatment outcomes. And amlodipine really is one of those very good calcium channel blockers. It has fewer side effects compared to other molecules in that class, and it is effective. So we picked amlodipine. So the other medicine that we picked was an angiotensin converting enzyme inhibitor. And the thiazide came in as number 3 for our protocol. And this is the protocol that we designed. So if someone had high blood pressure, we would initiate them on amlodipine, and in case the blood pressure was not controlled, we would step up treatment, bring in Valsartan was the molecule that we chose in that class of the angiotensin receptor blockers. And then if someone did not get controlled on those two medicines, the third medicine would actually be a thiazide. So still trying to simplify for colleagues who are not clinical, but the main point is that the selection of our medicines for the protocol were based on that landmark clinical trial, which showed effectiveness of these different medicines. And amlodipine would make a very strong backbone for a regimen. So here you can see that when we used that protocol, previously management of hypertension was a task by the doctors, for the doctors. But now you can see even a nurse is able to prescribe medicines for hypertension using that protocol, because it is quite simple. As long as the diagnosis is made, these people can be able to prescribe and manage hypertension and offload some of the tasks from the doctors. So what happened when we implemented this strategy? We trained the providers using these protocols and they implemented it. We look at some of the outcomes in terms of blood pressure control and HIV outcomes at 6 months of implementing this strategy. And for us to determine this effectiveness, the effectiveness of the strategy, we conducted a single arm pre-post study to really understand the effectiveness of this strategy. And we enrolled patients who had, these were people living with HIV who also had hypertension. We enrolled them to receive integrated management of hypertension and HIV care using the strategy that we developed. And we had a total of about 1,084 patients enrolled. We followed them up for about 21 months, and our primary outcomes were the number and proportion of patients who actually achieved blood pressure control at 6 months, but also at 21 months. And we also measured mean blood pressure, viral load suppression, and the other HIV and hypertension cascade outcomes. So to look at outcomes at 6 months, I'll show you the baseline cascade that we had, and the cascade that we had at 6 months of integrated care. And you can quickly see that the HIV care cascade remained optimal. That is the one in orange, both at baseline and at 6 months. But the hypertension cascade had tremendous improvements regarding initiating treatment, retention, monitoring, and control. Significantly, you can see that blood pressure control, the number and proportion of people with controlled blood pressure improved from about 13.6% to 75% in 6 months. So this strategy helped us to improve the cascade for hypertension, but sustained good care for HIV. And this shows that even when you integrate really, that the HIV outcomes are not going to be disrupted. This was the trend of hypertension control at 6 months, and there was improvement along the 6 months period. Mean blood pressure also significantly improved comparing baseline and 12 months, and viral load suppression remained high. There was no reduction in mean blood pressure. There was no reduction in viral load suppression, so it remained significantly high. So this was the trend of HIV and hypertension control over the 21 months. So you can see that the orange line refers to HIV viral load suppression, which remained at 99% throughout the 21 months. And the hypertension control improved to a maximum of about 73%. We had a decrease during the COVID-19 lockdown. The decrease here is when the COVID-19 came, we had a national lockdown and patients could not come to receive their hypertension treatment. But those patients who had hypertension could go to nearby HIV clinics and access antiretroviral treatment because it is available everywhere. But hypertension treatment was in very few sites, including our sites where we're integrating. So they could not actually have high blood pressure medicines. So we had a reduction in blood pressure control at that time. But when the lockdown was lifted, we see that hypertension control improved further to the original about 73% mark. So this shows that by about 6 months, one can be able to realize the optimal outcomes for hypertension. But even when you integrate the hypertension care, the HIV care was not actually disrupted. So we've really looked at the burden of hypertension, the gaps that we had in the cascade, and the strategies that we put up to close the gaps in the HIV and hypertension cascade, and the outcomes that we saw at 6 months and 21 months. So that was integration at the health facility level. And as we close, I want just to introduce our next step, where we are going to be integrating the management of hypertension into the community-based models of HIV care, still using some of the implementation science methods. And to do this, I'm glad that I competitively won this K43 grant, which is focusing mainly on the design an evidence-based implementation strategy to help us integrate the management of hypertension into community-based models of HIV care and be able to evaluate their effectiveness and implementation. And the basis for this is that in Uganda and many other sub-Saharan African countries, when people living with HIV get viral load suppression and they are stable on their treatment, many of them are given treatment within the communities where they stay. So they don't have to come to the health facility very frequently. Some of them can stay away about 3 months or 6 months. In this picture, you can see a group of people living with HIV seated under a tree, and the healthcare provider is there to provide them with HIV care service. And in some of these rural areas, there is minimal stigma. So everyone here actually understands that the neighbor is HIV positive and they're generally stigma-free. So, and about 40% of patients receive care through these differentiated community-based service delivery models. So if we've showed that integration of hypertension care is feasible for people who receive care in the clinic, but we also think that even these people who receive care in the community should actually have hypertension management integrated into their care. So that is the main basis, because we see many clients are receiving care in the community, but also they need to get access to blood pressure monitoring treatment for those who have both HIV and hypertension. So the aims of this community-based study are going to really focus on understanding the stakeholders' views on integrating the management of hypertension into community-based models of HIV care. And we are going to do this through use of qualitative research methods, interviewing the providers, patients, and some of the leaders to get their views regarding their experiences and their preferences on this integration in the community models. And based on that, we'll be able to design strategies to integrate care in the community models and determine their effectiveness. And for us to determine their effectiveness, we've designed an interrupted time series kind of pre-post study, which we are going to show, which we think will be able to help us to determine whether the strategies will be effective in improving hypertension control in the community. So the status of this study, we are just finalizing our protocol and we are soon submitting it for IRB review. But this is just to show you our predicted model for this study. So we are designing, we want to integrate the management of hypertension into community-based models. So we'll have two groups of patients. Some patients will be receiving care in the community and others will be receiving care in the clinic. And they'll both receive integrated care for hypertension and HIV. So our hypothesis is that when we integrate care for hypertension in the community models, we'll be able to improve hypertension outcomes, especially looking at controlled blood pressure. The secondary outcomes will be vital suppression, retention in care, and other outcomes. So we plan to conduct a pre-intervention, we plan to have a pre-intervention period of about 3 months where we'll be collecting data on hypertension and HIV outcomes before we introduce the strategies that we'll have developed with the stakeholders. And we think that when we introduce the strategies, we may have a lag period of about 2 months before we see significant improvements in blood pressure control. But after that lag period, we anticipate that we'll have both improvement in blood pressure control for both groups that will be receiving care in the community and the group that will be receiving care in the clinic. And then we'll use controlled interrupted time series analysis to determine, first of all, primarily to determine whether these strategies are effective in improving care in the community, but also to compare outcomes between the community and the clinic-based group. That's how we want to move in our next step. But just to brief you, building on the clinic-based lessons that we learned, we have an ongoing cluster randomized trial, which is also studying implementation of hypertension management in the clinics at a broader perspective. So this is the last, and as I conclude, I just want to remind ourselves of what we've gone through, and I think we've observed that we have a very high burden of hypertension among people living with HIV, and generally the services for hypertension and HIV are still vertically oriented in many settings. But from what we've seen and the lessons that we've learned in our research is that integration of services for hypertension and HIV at the health facility level is feasible and can be effective. And our next step is to really study integration of hypertension management into HIV care within the community-based models of HIV care and study their effectiveness. So thank you for listening to me, and thank you for giving me the opportunity to present our work to you. Thank you so much, and I appreciate my mentors, Professor Moses Kamya in Uganda, Dr. Luke Davis here at Yale, and our other collaborators. Thank you so much, and we appreciate our funders. The Fogarty International Center funded my Global Health Fellowship program, and that is how I started to do this work under the mentorship of Jeremy Schwartz, who is based here at Yale, and Isaac Senabulia, who is based in Uganda. So I've moved on to grow in this area, and I appreciate all the mentors, Fred Semitala and others who have been able to support me. Thank you so much. Over to you, Dini. Luke.
Thank you, Martin, for this fascinating work. I see that we have a number of questions to address in the chat, and we'll be getting those in just a minute. If you have your questions, please add them there. And but first, I'd like to welcome Dr. Hassan to kind of comment on Dr. Mudu's presentation. Thank you so much.
Thank you so much, Dr. Mudu, for an absolutely fabulous talk, an amazing body of work. So I'm Sadia Hassan, assistant professor at Emory after many years at Yale. And just to let you know the hat that I'm wearing as I come in to discuss this work, I've been a student of implementation science and Dr. Davis since 2014, when I first started looking at the integration of HIV care into a methadone clinic in sub-Saharan Africa and Tanzania. And so bringing in the implementation science lens, but also my experiences with integration of care. So really your work is a critical contribution to the field of HIV and NCD care integration, but I think really also the field of implementation science as you have applied these principles in a low and middle income country. I also think it's a beautiful example of an evidence to practice gap, and you very nicely walked us through the process of identifying contributors to a problem, clarifying an approach and strategy to overcome those challenges, and then evaluating the effectiveness of your implementation strategy. So really, thank you. This is a case example to be used in many implementation science courses, I think, moving forward. And a few thoughts and I think comments, and I think some reflect some of the questions in the chat. So in implementation science, we rely a lot on frameworks. And I often tell my students that, frameworks are a crutch. It's something we rely on for help, and it gives us that theoretical grounding to ensure that we're not forgetting, considering factors or domains, and providing us with a common language to communicate with each other. And I think you beautifully illustrated the use of definitely the consolidated framework for implementation research and the behavior change wheel. But at the same time, we know that frameworks have been developed in high-income countries, and many of us applying them to low and income settings very often counter challenges, things that are not relevant to our setting, or things that have not been considered. And so I'd love for you to reflect on how you've used these implementation science tools and some of the challenges that you've had in applying them, and some of the lessons learned that you could perhaps share with those of us trying to use similar frameworks in our settings. The other point is around adaptation. And I think the field of adaptation in implementation science has grown tremendously. And for us working in low and middle income countries, and as we adapt interventions to our settings, thinking very critically about what we choose to remove, what we choose to modify. So using the kind of Sturman et al.'s frame model, what is being adapted, who is adapting it, and why? And I noticed as you developed your strategy with stakeholder engagement, there were some things that were removed, notably the lifestyle change package, right? The healthy lifestyle. And so if you can reflect on your process of adaptation and the selection of components to include, to modify, and remove, and how you might study then what its impact is on the HEARTS package as a whole and its effectiveness in your setting. Lastly, again, your results are incredible. I mean, I think anybody who looks at those graphs is like, okay, this most certainly works. It is incredible. How do we scale up and how do we scale out? And that leads me to ask you about your implementation outcomes for the study. And I would love to kind of hear whether you looked at things like acceptability, fidelity to the protocol, and importantly, I think, which is questions in the chat, sustainability. And I say this because as we pile more and more on nurses, acceptability of these types of interventions with task shifting seems to wane over time. So I'd love for your reflections on that. In addition, one of the key components of your strategy, or one of the strategies that you used, was the free medication. And so to what degree is that sustainable over time? So as your program and your group thinks about scaling up, what can we learn from that? And perhaps if there's been thoughts about a cost effectiveness, for example, study to kind of look at the long-term sustainability of things like this. And so I really want to commend you on your work. I cannot wait to hear some of these reflections, and I think some of the other questions also in the chat. Really, many congratulations, and thank you so much for your work.
Yeah, thank you so much, Dr. CIRA, for those reflections. Indeed, they are very important. Just to respond, I'll start with the last one because I think that's the most important one. Implementation outcomes. How sustainable is these strategies, and how acceptable are they to the different stakeholders? I would say that we conducted a process evaluation of this study, and our paper is under review. But just to share some of the findings is that sustainability is still a challenge, because we had a grant from Resolve to Save Lives, which helped us to procure these medicines. And when the grant time ended, we could not procure these medicines further. But we worked out some strategies, although they are long term. During the design of this strategy and during implementation, we worked together with the Ministry of Health policymakers, both from the AIDS control program and the NCD department. And with these findings, immediately the Ministry of Health swung into action, and they started to revise the national guidelines. The 3 guidelines. One was the essential medicines list for Uganda, because the essential medicines list for Uganda had very old, outdated medicines for hypertension. You could imagine medicines like nifedipine were the key medicines for us in our national guidelines. Medicines like atenolol, you did not have amlodipine there, you do not have an SE inhibitor there, you did not have a thiazide on those guidelines. So even the national program could not procure these medicines with the limited resources they had. So we had a number of engagements with the Minister of Health. They revised the essential medicines list, at least to include the effective molecules, so that even if they are to procure less quantities, they are procuring the good medicine. So that one has been achieved, and we've been able to engage the ministry, and they have been able to achieve that. So that in the long term helps us to empower the Ministry of Health to procure the medicines that really are going to be effective. In the same line, the Ministry of Health also revised the Uganda clinical guidelines to include these medicines there, but also to include the good practices that were seen from this study and the other preliminary studies in this area in the country. And the third guideline that has been revised is the Uganda guidelines for HIV care, with a lot of support from PEPFAR. The treatment protocol that I showed you has been adopted and has been expanded to include other classes of medicines or other options of medicines in those different classes. So you have like telmisartan, valsartan, you have lisinopril. So whatever is available, a healthcare provider can be able to prescribe it, but with good guidance. So we've seen HIV guidelines, the essential medicines list, the Uganda clinical guidelines revised to include these medicines, but also to adopt a protocol which can help healthcare providers to prescribe. So that in the long term will be able to help us as a country to get sustainability in terms of access to medicine. The picture is not yet good enough, but we think those are some of the strides in a good direction. So in terms of effectiveness, acceptability and reach, we still think that there's a lot of resources that are needed to be able to reach everyone, but this responsibility is really for the government, and the government coming up with better policies and guidelines is the first step really to scalability. But in the same line, we have our team also competitively won another grant from the NHLBI, a UG3 grant, where we are conducting a cluster randomized trial across 2 districts in Kampala, in Uganda, Kampala and a neighboring district. And in that trial, we are studying both effectiveness and implementation outcomes of this adapted WHO HEARTS strategy at a broader scale. And we think we'll be able to learn more lessons from that trial, both regarding the effectiveness and regarding the implementation outcomes, looking at, and in that we're also conducting cost effectiveness analysis. But a lot of that work is focusing on clinic-based care. And in our ongoing work for community-based integration, I think we should be able to include, we did not, but we think we should include an aspect of cost evaluation to look at how cost effective it will be to integrate these kind of strategies in the community-based models of HIV care. So those are some of the strategies to understand implementation outcomes, but also to look at scalability and sustainability. And lastly, on your comments, you raised a very important point. The frameworks are helpful to help us think about the different domains of our healthcare system and stakeholders, but also to generate generalizable knowledge. But the limitations are there, and some of the domains do not resonate quite well with the low-income settings. For example, the CIRA did not have components of funding or financing, but there's now a revised version of the CIRA. I think it's taking care of those components. But at that time, we did not have those domains. And it is true, when the financing or the funding ends, some of these strategies will have to cease. So those are some of the limitations, but we are trying to work with the government, and we engaged these policymakers right from the design, even during implementation, and we worked through with them up to, we even published this work with them, they are co-authors on this work, so they own it up and they quickly integrate it into the national guidelines so that many more people can benefit from this kind of initiatives. Hopefully I've tried to respond. I know there are very strong points, but that's what I could say for now. Thank you so much.
Thank you, Martin. Really superbly done. We've got quite a few questions here, and we only have about 3 minutes left. So let me just kind of highlight two things that I think the groups is generally interested in. One is, what other aspects of the HARD strategy are you considering implementing? And I think there's particular interest from Danielle Warren Diaz in the lifestyle change intervention, how you're considering that. And then I think there were also quite a few questions wanting to know a little bit more about how you're planning to do the community-based work with your K43 in terms of how you're going to engage the community and what are some of the strategies you might be considering to promote uptake of hypertension care in the community.
Yeah, thank you, Luke, and thank you, colleagues, for the comments and the questions. Lifestyle strategies, we actually did not leave out lifestyle, but we thought that lifestyle management is part and parcel of care for hypertension. It's not really a strategy, because we thought about strategies as the things that are going to help us to improve uptake of the care. So from one of the guidelines, it's recommended that if someone has high blood pressure, they should receive treatment in terms both medical treatment plus lifestyle care. So medical treatment goes hand in hand with lifestyle. So we thought that that was already a component within the treatment itself, but we did not leave it out. So we did not take it up as a strategy, but we included that in the protocol as part of the treatment package, and we did not reflect it as a strategy. So that's one thing that we think that maybe the WHO, as a guideline, it is right, but for us as a strategy, we did not include it, but it was implemented as part of care. And some of the strategies that we are thinking about for the community intervention, one of them, we are thinking about integrating drug distribution, because ART is given in the community. We want to be able to screen in the community and treat. One of the things would be working with the community health workers to create demand for these services, but also to help us with retention of these clients in care. But it will also require robust systems for monitoring. If someone is given a service under a mango tree in a community, how do you document those services, and how do you monitor? How do you monitor blood pressure? So community-based monitoring for blood pressure, good monitoring systems for community services, and we are hoping to use some electronic records. But we will refine these strategies working with stakeholders. I don't now know what exactly is the best way to do it, but once we go to the stakeholders, I think we'll come up with the best strategies. Still using the HARTs as a backbone, we will adopt. Thank you so much. Thank you for listening, and over to you, Luke.
Well, thank you again, Martin and CIRA, for a fantastic conversation. Please, everybody who's here today, feel free to reach out to Martin if you have further questions about his work, and we'll pass along the questions that we weren't able to address. Thanks also for attending the CIRA events. There'll be an evaluation that comes to you just as you close out, and please give us feedback on what you'd like to see more of here on these webinars. So thanks again, Martin and CIRA, and to all the audience. We look forward to seeing you again at future webinars.
Thank you so much.
Thank you, everyone.